This talk actually grew out of a Palm Sunday retreat that I was invited to by a very clever woman religious who, under the pretext of meeting her brother, and actually out of that, I went to the first Courage conference that I ever went to in Villanova. And while answering some questions in a breakout group, the issue of transgenderism came up. And out of that, Father Czech recruited me in his inimitable way. Last night, he confessed to you that he was a Marine, captain of Marines, commander of tanks. And one of the things that such people do is they call in close air support. And so I'm the close air support. And you know, it sounds funny, but it turns out in looking into it that Father Czech and I both served at the same time in a combined arms exercise with the Marine Corps. So he was rumbling around in the tank while I was flying overhead dropping ordnance. 30 years later, here we are, we're talking about human anthropology. Isn't that amazing? Yeah, God is it never ends, does it? Okay, so that slide's not complete, but let's just stop for a moment and offer a prayer of thanks to the Blessed Virgin. In the name of the Father, the Son, and the Holy Spirit. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Amen. Our Lady of Perpetual Help, pray for us. Amen. In the name of the Father, the Son, and the Holy Spirit. Okay, so the challenge that this talk addresses is the challenge as clergy, as physicians, psychologists, therapists of the Catholic faith. We're challenged to bring the good news of the gospel to people who are entrusted to our care. And in doing so, we were reminded that the grace that comes from that witness is the same grace that perfects our nature and perfects the nature of the people whom we are serving. That's the point of all of it. And our nature includes our sexuality as well as our profession. So as we do this, as we grow in grace, it perfects us in our humanity. And part of our humanity is the work that we do. That's one of the dignities of being a human being, is work that advances the cause of righteousness, right? So, okay. But we're evangelizing people who are being continuously lied to about the things that we're addressing today. Sometimes willfully lied to, sometimes out of ignorance, that things are being misrepresented to them, but it's on a daily basis, particularly in matters concerning what human sexuality is. So we're talking about a need for catechesis at all levels, at the level of the parish, at schools, in the wider community, at work, everywhere. And it's also it's a witness that has to have pastoral sensitivity. So as Dr. Smith showed us clearly earlier on, you really have to be careful about the words you choose and the way you present it. And behind all of that is the fact that we're all in need of sacramental grace. So bringing people into the life of the church by witnessing to the truth, the beauty, and the goodness of what all this means is really what we're called to. So what I'm specifically addressing this afternoon is the T in the LGBT. And we're presenting these issues to a generation to whom the words male and female, he created them, has been utterly replaced. So it's very hard to begin with biblical truth to people who are biblically ignorant or not fluent in the language of the Bible, or perhaps not even interested in it, but are still in need of the grace of God and life in the sacraments. So what it's been replaced with is this confusion of exceptional cases, that everything is an expression of an exceptional case, and a very aggressive recharacterization of what it means to be a human being. And this is everywhere. It's in academia. And when I say academia, I'm not just talking about universities any longer. Academia now means 5th grade, right? It does. It does. I mean, the idea of gender fluid, I hear 5th graders talking about stuff like that. I actually was invited to present at a middle school some months ago because a 7th grader was presenting herself to her classmates as being a boy, no longer a girl. And there was this tremendous discussion that had grown up around that. And we're talking at parochial school. This isn't a public school, it's a parochial school. So, and certainly entertainment and as recent events show, in the law as well. So the idea is that we have to understand the teachings of the church in the language of the church, but we have to be able to carry it out into the wider world. And in order to do that, I'm going to present to you the language of plastic surgery. which is probably something you didn't expect to get when you came to Phoenix, is a seminar on what plastic surgery is all about, but you'll get that. And we'll also seek to understand the historical developments of these very worldly dogmas that we're dealing with now. The point of all of this is to be so familiar with the language of the world and the language of the church that we'll be able to witness with patience and with love, and we won't be taken by surprise, we won't be taken aback. We'll be able to calmly witness to the truth because we're in the business of winning friends, not winning arguments. Okay, friends for Jesus, bringing them into the truth and the beauty of life in the church. So one heart speaking to another, as John Henry Newman would say. Okay, the difficulty we're met with is that the language that's used in this discussion is this constantly shifting language. 1 minute it's using the language of biology, the next minute it's the language of psychology, the next minute it's political language, and all of it mixed together, and constantly you're having to jump from one worldview to another to try to answer the questions. But what is proposed behind all of this is that human sexuality is a spectrum, not an objective reality of complementarity, but it's a spectrum. And it's at this odd intersection of lifestyle choices and meeting biological constraint, okay? And biological constraint is something that in the minds of the world is evaporating. Biological constraint, as we heard about earlier in the day and at the end of yesterday, is something that's malleable and subject to scientific advancement, and that there will come a day when you won't be constrained by the realities of your body. It's just going to be strictly a matter of the action of the will, choosing the physical expression, whatever you want. So there are great expectations behind that the day will come that people will no longer have to submit to the objective realities of their biological sex. And behind all of that is the use of this term outcast, that people feel as if they are outcasts because of the way they feel about who they are. And this march of human progress, this inexorable march of human progress, is aimed at overcoming this sense of alienation that persons have with transgender thinking, okay? And progress is seen as this inexorable, historic, you can't resist it, here comes the big railroad of progress that's going to push you out of the way if you don't follow along with what we're proposing here. So, okay. First of all, now we're going to jump into plastic surgery, very briefly. It's the oldest form of surgery, and for obvious reasons. It's because it's primarily surgery of the skin structures, and before the era of anesthesia, it was the only kind of surgery you could perform without killing somebody. Cavitary surgery in the chest or the abdomen is a very dangerous thing if you can't manage people's vital functions. So plastic surgery has been around for a long, long time. And some of the oldest documents that show plastic surgery at work are for two particular conditions, interestingly enough. One is ear reconstruction in India, and the other is nasal reconstruction in Italy, both of which were disfigurements that people would suffer at the hands of their enemies in order to separate them from life in the wider community, right? So if you were the subject of vendetta and somebody didn't want you presenting yourself in public, at court perhaps, they'd cut your nose off, and then you couldn't present yourself in public, so you were an outcast, right? So plastic surgery used to manage the sense of an outcast, but somebody who was objectively disfigured. And so the plastic surgery techniques that were developed by the people in ancient India and in Renaissance Italy were aimed at restoring a person's presentability in society. And here's the example from Italy. This is Gaspar Tagliacotta's brilliant means of reconstructing the tip of a man's nose by using the skin of his upper arm. It was a very involved process. It's a beautiful thing. But yeah, I mean, imagine walking around like that for a couple of weeks. But these are techniques that we still use. It's called waltzing a flap. In this case, waltzing a flap of arm skin to the tip of the nose so that you can make a presentable face, okay? So the basic principle there is the establishment or restoration of form and function, right? So based upon a thorough understanding of the nature of the missing or injured part and its relationship to the person. So you can study this, structurally what a nose is. It's got skin, it's got lining, it's got cartilage, what its general shape is, what the dimensions of the passage has to be in order to admit air so the person can functionally breathe. And you can also make very nice aesthetic judgments about what the shape of it should be. It should be a fifth the width of the face and a third the height of the face, and so on. The same as the width of the opening of the eye should be the base of the nose, and all these aesthetic things that you can say about noses, and you can apply that to the restoration of form and function and make a very presentable nose. And so restoration that may have been lost due to trauma, as in the case of the vendetta, or surgical management of disease, as in the case of malignancy, or destructive infectious processes, or loss of blood flow, or one such thing or another. Sometimes it's what's missing at birth from developmental abnormalities or adverse events in utero, like what's called amniotic band, auto-amputation of a part like a finger or even a hand. So probably the most moving example would be clefting of the face in a child. These are 4 examples of clefting. This is a congenital malformation that has a variety of in utero causes, sometimes genetic, more often exposure to certain substances, and sometimes just position of the child in the womb. But in seeking to repair or remedy this condition, you have to consider a whole lot of different things besides just the appearance of the face. You have to understand that there are feeding difficulties involved, that the child will have difficulty being understood because they can't form what's called plosive phonemes. They can't make the p and the t and things like that. So they start having difficulty being understood. They become frustrated as children because people can't understand them. Associated hearing problems. They can't hear clearly, so they can't hear what they're supposed to sound like. And it's a big deal. It's a big deal. But it's been studied extensively, and we've gotten pretty good at fixing it, right? Yeah, and so it's a team that takes care of it, and all of it is based on an understanding of what a child is called to be and what's gone wrong, what's missing, and how we're going to fix it to restore form and function. Function, of course, is not excused because you're more interested in form, and likewise, how unfortunate would it be to restore excellent speech if the child couldn't feel that they were presentable in public? So it's a unity. So. Now, the degree of functional restoration sometimes is dictated by the intrinsic function of the lost part. So I'll give you the example of a hand. We make distinctions. Is it a dominant hand? Is it a helping hand? Is it a left hand on a worker, or is it a left hand on a young lady? Is it a left hand that's more interested in presenting a wedding ring, or a left hand that's more important for holding work, gripping work, so that you can work on it with your dominant hand? All kinds of things that go into hand reconstruction. Here's an example of an adult male who lost his thumb in a punch press accident. It's his non-dominant helping hand, and mostly what he needs is a good grip and key pinch function to manipulate things. You're looking at it, you're saying, hey, there's a thumb there. Well, that thumb used to be his index finger, and it's been policized. It's been shifted over to the base where his thumb is. And he's got the cartoon kind of hand with 3 fingers, right? But it's a fully functional hand, which in a working man is exactly what you want. So we surrendered a little bit of function, a little bit of aesthetic, for the sake of function, because in the case of a working man, function trumps most everything. Whereas if this had been, a 19-year-old girl, we would have probably spent more time in the aesthetic splendor of a left hand that's presenting a ring, right? Okay. Now, those might be old-fashioned considerations, and that might be slipping into the past, but that's how I was trained anyway. So there's another thing we have to consider, though, in plastic surgery. We've talked about restoration of form and function, but there's also the aesthetic side of surgery. And aesthetic is not a little thing. Aesthetic, of course, literally means feelings. And so aesthetic, when we speak of aesthetics, we're speaking about how what we see affects the way we feel about things. And it's a very personal and subjective issue. And sometimes aesthetic can be distorted by interior wounds, where people will have a distorted sense of themselves, and they'll seek an explanation in their appearance. Okay, there's an interior sorrow, there's an interior wound, but they're looking for an outward explanation for why they feel the way they feel. Now, these are all pictures from the public domain, but I'm just going to go through this to sort of show you an example of how a distorted sense of self and returning back to surgical intervention will eventually, you'll start to see that there's something more going on here than just an ordinary search for ordinary aesthetic thing, right? Yeah, and so what we're looking at is a person who is trying to heal an interior wound with external surgery, okay? That's easy to understand when you see the example. Okay. So now we're going to move to the whole issue of gender identity. we have to understand how the secular world has come to see sexuality. And in order to go through that exposition, we're going to look at the three sources of the language we talked about, the language of biology, the language of psychology, and the language of politics, to understand the origin of this gender identity issue. So I like to speak of the unholy triad of errors of the 20th century, right? That gives us this false human anthropology that is the current worldview about where human sexuality comes from. It's the explanation for human behavior in a materialist worldview. So it begins with the idea that matter precedes thought, right? That we live in a godless universe, and human thought, the human person, is a product of sufficiently evolved matter, right? The human person evolved from random and pointless events, and that persons are motivated by drives for pleasure, the zenith of which is sexual in nature, and that the sexual life is a political expression. Okay? And we see in current events how that's become the politicizing of human sexuality as an expression of liberation. Okay. From Freud, we got the pleasure principle, the idea, this linking of the drive for sexual gratification. And he had a difficult time there poising this life instinct, this search for pleasure, with this apparent disorder in humanity, that human beings are the only creatures that seem to work against themselves inexplicably. And he came up with this thanatos, or death principle. It got kind of confusing towards the end, but I think one of the key elements that Freud contributed to this confused dialogue is the idea of infant sexuality. He's the one who introduced the idea that the quest for pleasure is always sexual in nature. It's just that sexuality in an infant is infantile sexual. So he basically blurred the whole issue of sexuality right down to the youngest of our fellows. Okay? This impulse to pleasure became more scientific, or science-ish, as I prefer to say, when it became bioenergetic, the idea that we're managing biological energy through sexual expression, kind of gave it a sense that it's more scientific than it really is. And this proposal that there's actually a life force, or what Dale Hudson calls the hydraulic principle of sexual impulse, that you get to a certain hydraulic pressure and there's just no resisting it, right? And that's Wilhelm Reich's idea, and he's the one who coined the term sexual revolution. So here's where we see the politicizing of human sexuality with this whole bioenergetic principle that he introduced. So we're given this either-or choice to make. How are gender and sexual orientation determined? It's either inheritance or it's socially conditioned. But what I would propose to you is this: does it matter? Does it matter? Now, it matters if your goal is the intercepting whatever processes cause it. But when you're presented with somebody who has this sense of themselves as being the other gender, it doesn't really make much difference. For the same reason that it doesn't make any difference to me in a child who has tuberculosis, whether that child got tuberculosis because in their first years of life they lived in a household full of people with tuberculosis, or if they got it vertically transmitted to them in utero. The child has tuberculosis, right? It begins with a definition of what health is, what the integral human person is. And if there's something wrong there, something integrally wrong with the child, it doesn't matter whether they were born that way or they acquired it. You have to understand that this is not commensurate with a healthy human person, right? Yeah. Now, so in terms of the transgender business, it's sufficient for this conversation to accept that this is not congruent with a healthy life. Okay? So, does it matter? Where did we get these ideas? It can really be traced back to this man, John Money, pediatrician, psychologist, and sexologist from Johns Hopkins University. And it's important to understand that he worked on a team of professionals who managed various what are called intersex conditions. The word intersex is used today. We used to use the word hermaphroditism, or children born with ambiguities of their genitalia, ambiguities of their external genitalia in particular. And so these are very challenging problems, and it required a team for managing them, just like the cleft palate team. You've got audiologists and speech therapists and everybody else working there. So it is the case with intersex or hermaphrodite ambiguous genitalia children. So he was part of that team. And these are objective disorders, okay? When a child is born with abnormal segregation of sex chromosomes, like a child with Klinefelter syndrome who has XXY, this is an objective reality. You can do a buccal smear, you can do a genetic karyotype, you can look and go, oh, this child has an XXY genotype, and then you can examine the child and go, oh, it makes perfect sense, and here are the findings. Or you can have a child born with, bladder exstrophy or some other structural problem, and you can look at the child and go, yeah, there it is. This is the problem that we have to manage. Here's the example of Klinefelter, and it's important to know this because this example is used to blur our idea of what normal human sex determinants are. The fact that there's an exceptional case is used as some kind of a cudgel to convince us that there's no such thing as an absolute male or female because there's an exceptional case. Well, that's what it is. It's an exceptional case. Males born with XXY, 1 in 500 to 1 in 1,000 live births, they have variable, what's called phenotypic expression. The genotype is XXY. Phenotype is, well, what do you see? And you might see variability in the hair pattern. You might see variability in the size of the breast or the shape of the pelvis or the length of the leg compared to the height of the body and things like that. It's basically a gynification or a feminization of a male body. And it has objective criteria that you can examine. And it's an example of an intersex condition. And these are the types of patients who would be presented to Dr. John Money. Objective realities that need objective intervention. Now, in the days when Dr. Money was first at work there at Johns Hopkins, there were efforts made at what's called sexual assignment. So you would look at the condition of the child and you would ask yourself, well, what is the best possible course here? If they have ambiguous genitalia, what kind of modifications do we have to make in order to give them as much function as possible so that they're able to void without soiling themselves, so that they're able to possibly have sexual relations as adults should the day come. But it should also be understood that in those days, about everybody got modified to female because it's just a lot easier to do, okay? It's a lot easier to make a neo-vagina than it is to try to construct a penis. And so that was just the nature of, that's the surgical limitations of this particular problem, okay? But there were members of the team, like Dr. Money, who were involved in the psychological support of these children. And what he brought with him, I'm going to just move along here because we are time sensitive here. The idea behind the work of this team was to remedy a structural problem that interferes with actual life issues, an objective reality that's causing, that serves as an impediment to the fullness of life, okay. Right? So, based upon his experiences with intersex patients who early in life were assigned male or female, again, most of them were assigned female, but nonetheless, he proposed that apart from the reproductive and urinary necessities of gender, that gender behavior was malleable and totally socially determined. That was his proposal there, that gender is a social construct and that sex is just a biological accident, okay? Remembering, of course, that the patients he was seeing in this clinic, massive selection bias, because you've got people coming into that clinic who have objective chromosomal assortment problems or hormone receptor abnormalities or all kinds of other actual objective things, and he's trying to apply that to the wider human condition and saying, oh no, it's all a social construct, because he was seeing some success in saying, you shall be a girl, we shall raise you as a girl. Yeah, so, okay. So the question is kind of a hammer and nail question. Is gender behavior genetically determined or socially conditioned? The problem with asking such a question as a psychologist is that there's so many variables that impinge upon it. And so there's a supremacy in these kind of questions of what's called a monozygotic twin study. If you can find identical twins and subject them to this variable of social conditioning, then you can actually answer a question like, well, is it genetically determined, X, Y, or XX, or is it socially conditioned? And it's what all psychologists look for as the perfect test, perfect control of genetic variation. And he got that. He got that in the case of these twins who were born up in Canada. And when they were presented for circumcision, the first child was mutilated by a new device called an electrocautery device. His pediatrician mismanaged the whole situation and utterly destroyed the poor boy's penis. And so the parents, very much distraught, it happened by accident that they had seen Dr. Money on some public television presentation talking about this intersex clinic, and they thought, this is the answer to our question. We'll go there and we'll solve this young lad's problems. So they presented. And so this presented Dr. Money with the perfect case. This is what he's been waiting for professionally. Here are twin boys, perfectly normal, perfectly healthy, and one of them has suffered this terrible accident. And so he convinced the parents to raise that child as a girl, which included not just socialization, insistence on girls' clothing, insistence on girls' toys, insistence on everything girl, 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 including castration and the use of exogenous estrogens in adolescence. And the goal was going to be to create a neovagina, as you would with a child who was born with bladder exstrophy and ambiguous genitalia or something like that. But this was a child who was absolutely normal, who had just suffered this accident. So that was the goal. And based upon that, here they are, sort of in the middle of that process. He began to generate a lot of scientific papers for the psychological community, the psychiatric community, the pediatric community, the wider political community, about this wonderful and convincing example of a monozygotic twin pair and how gender identity is totally socially conditioned, and reported it to the public as a wild success. He would speak of the girl as being a wonderful, charming young lady who in every way is just a precious little girl. And everybody's happy and everything's going well. It became a very celebrated study. And here is the boy who was wounded, mutilated, and is presenting as Brenda. Okay, so these were being published in what are called, euphemistically, peer-reviewed journals. The power of science. So if you say peer review, everybody bows and says, yeah, this is the truth, right? And that this was successful in every way. And it took on a very strong political dimension because this was seen by the burgeoning feminist movement as an explanation for all that's wrong with the world. It's the oppression and forcing women into gender roles. And this is an example of how gender roles are strictly social constructs. And it took on the language of politics. So we've gone from biology to politics in one swift step. Okay, so this scientific basis for gender in politics was based upon this idea of sex assignment. And this is the word that's now used. It's a very in vogue word, that when a child is born, you look at their genitals and you assign them a sex as being some kind of an act of oppression rather than an act of objective recognition. This is a boy. Now, so and they could refer now to Dr. Money's example as proof that this is the case. This is conclusive proof. The problem is that these children were being brought for annual evaluation with Dr. Money, and what was actually being demonstrated here was that the young girl was actually the tomboy. He was a very rambunctious fellow who didn't like girl play, and because he was so rambunctious, the girls didn't like having him around. But because he was dressed in dresses, the boys didn't like having him around. It's a horribly miserable life he was living. And he wasn't fitting into the role that Dr. Money envisioned as a total success. So in order to force the success of gender identification, when they would present for their annual evaluation, he would force them into naked sex play, which he would also photograph. This is, right, trying to force this behavior on the child. But there he was, the rambunctious tomboy. And finally, he was given the truth at age 15. And he said, essentially, thank God, I always knew it. But at this point, he had been castrated, so he needed to have exogenous androgen hormones given to him. But he fully embraced being a boy and then being a man. It required some exogenous, surgical support, and he was working in the direction of of a meaningful reconstruction. And Dr. Money, for his part, just stopped talking about it. He didn't print any retractions. He didn't come out and say, you remember that case that we developed all these papers and journal articles about? Turns out it didn't work out as well as I'd hoped, and there's never said a word about it. Never said a word about it, never took any of it back. David, for his part, did everything he could, within his strength to live the life of a man. He courted and married a woman, adopted her children, right? But the wound was pretty deep for him and his brother both. His brother battled depression. They both did, actually. His wife left him after 14 years, and then not long after his brother died of a drug overdose, David took his own life. So, and I put that out there as an example. I just put it out there to show you the foundation, the sand upon which this whole thing is built. Okay. Is this an exceptional case? No. We have to understand, as was spoken about earlier in the day, that the human person is a unity of spirit and form, right? That there's an intrinsic nature to the maleness and femaleness in which we have been wonderfully made. This same case that I just presented to you is cited by the transgender community as being a horrible case only because the child wasn't given the choice. So the objection to the case is not the obvious evidence that there is an intrinsic boyness about a boy and an intrinsic girlness about a girl, but that he wasn't given the choice, that we should have waited until he was older. Meanwhile, children who express the slightest interest in being the other gender now are receiving hormone-blocking drugs and raised up as if that is the way to live, ignoring the fact that over 92% of them will spontaneously abandon that mistaken idea in adolescence, early adolescence. So, gender surgery has gained mainstream credentials because of this. And this ubiquitous citation of Dr. Money's studies and writings is supported by large professional agencies, including my own Plastic Surgery Society. There are articles constantly coming out about the improvement in techniques for gender affirmation surgery, as it's called now. Right? Okay. It has tremendous political power, as you know. And it has that political power because of this counterfeit charity that undergirds it. It's presented as a life-saving medical intervention now. Because we have to do something about the despair that this person is suffering with that may lead to their own suicide. So we're compelled by this counterfeit charity to offer surgical intervention and all that attains, including hormonal manipulation and all the rest of it. Why? Because if we don't, they'll take their lives, and obviously that would not be good for the human person. So how does it start? Well, okay, it's based on a diagnosis that there's this disconnect between genotype, phenotype, right? That's in disagreement with a psychosexual type. And that, furthermore, the treatment of the psychosexual type is impossible and cruel. So you're forbidden to speak about the underlying dysphoria, the underlying lack of congruence in their life. You can't speak about the psychological component because that is cruel. You can't talk about that. You have to just get after changing their appearance. It's politically unjust to diagnose and treat the psychological condition. But underneath it all, of course, we understand that you're trying to heal an interior wound with external surgery, which is not in the service of the good of the human person. Okay. Now, how does it actually happen? How does this transition actually happen? Well, it begins, and it should be understood that people progress down this road of transgenderism to varying degrees. Many people will just cross-dress, but as things go along, more will be undertaken, and some people go all the way down that road. So it begins with psychosocial testing to determine gender preference. To look at those psychosocial studies and consider them unbiased is quite laughable, really, because the persons arrive at the test desiring to be accepted into the process of transitioning, and they've been heavily coached in how to give the right answers so that you can immediately be started on hormonal therapy, right? So it's like, studying for the test. It's kind of like public education in general sometimes, but sorry. So it begins by living the life of the chosen gender, beginning to present yourself in the other gender. The mannerisms, the language, there's even speech coaching, voice management, bodily hair management, all kinds of things that go into living outwardly in the community as the chosen gender. And then it may progress on to the use of exogenous hormones. And then the next step would be surgery on secondary sexual characteristics, like the brow ridge or the thyroid cartilage or breasts, things like that, to try to feminize the face, sometimes lip surgery, nasal surgery, all kinds of things that are done. Those are considered secondary sexual characteristics, and a smaller percentage of people will go on to the final, what's called genital surgery, or euphemistically called bottom surgery. So everything else is called top, and then there's bottom surgery. That's the euphemism that goes along with it. So, okay. So what you can expect from the hormonal therapy, I gotta keep track of the time here. What you can expect from the hormonal therapy is varying degrees of effect in expression of the other sex secondary characteristics, like facial hair growth and the use of androgens, or breast development and the use of estrogens. We talked about these other secondary surgeries, but the thing to remember is all those secondary procedures are utterly reversible. I can change your nose from a feminine nose to a masculine nose. I can change it back again. I can take away your brow ridge. I can give it back to you again. I can give you a masculine jaw. I can give you a feminine jaw. These things are quite reversible, but there's nothing reversible about genital surgery. It's a permanent, irreversible mutilation of the human person. And there's no other word for it, and we'll get into the details so you'll understand that here. It results in permanent sterility. It's a permanent dissociation of the unitive and the procreative functions. Okay? Permanent. And in the majority of cases, even the unitive aspect of the sexual embrace is radically hindered, if not utterly destroyed. As an example, if you take the male genital and you turn it into the female genital, that is to say, you take the phallus and you invert it into the pelvis so that it is now a vaginal canal. First of all, it severely damages the nerves that supply the skin involved, severely degrades that. It still has the same central neurological connection as a genital, but it's severely degraded. But it hasn't in any way altered the mapping of the brain, so that when such a person has intercourse, their brain is telling them penis. Do you see what kind of a massive disconnect is involved there? Right? Yeah, and that's just the unitive side of things, right? Severely degraded, but it's utterly separated from the procreative aspect, which has been utterly destroyed, irreversibly destroyed. Okay. Okay, that may be true. That may be true. But we need to offer them this surgery because they feel as if they are outcasts, right? That outcast theme is returned. And if you don't, there's this tremendous risk of suicide. Well, this is a paper that if you're interested, you should be familiar with. And again, this is going to be sent to you if you ask for it. This is a paper that was published in Sweden just a few years ago. And it's a very important paper because it takes away from the conversation what is considered to be cultural bias. That is to say that one of the explanations for suicide among persons who have transgender ideation is that they're not welcome in society and they always feel isolated, and because of their isolation, they become disconnected from things and become more suicidal and self-damaging. So, but in Sweden, that's not the case. Sweden is a very affirming of this kind of gender mentality, very affirming of alternative sexual lifestyles. But the other advantage that the Swedish study has is the way they manage health data. Everybody who is born in Sweden is followed in the health record until the day they die, right? And so you can have a cohort study of people of exactly the same age, even born in the same region of Sweden, who have the same other variables like, use of alcohol, or are they hypertensive, or are they, whatever you want to look at to create a cohort. You can find a cohort for the person that you're examining here. And they looked at the effect of transgender surgery on overcoming the suicidal, self-damaging aspects of unanswered transgender thinking. Operate on them, don't operate on them. And essentially what they found was that When you operate on persons who feel themselves to be the wrong sex, the suicide risk goes way down. The suicide risk goes way down, right back to like baseline levels for the general population, but only for a time. There appears to be a period of time of somewhere between 7 and 10 years, somewhere in there, where the excitement and the affirmation of the decisions that they've made keeps them very enthusiastic for what's happened. But there comes a day when when the hue and cry is gone and all of the demons return, and the suicide rate returns to the baseline level that they had before they had the surgery. 41% before surgery, 40+% after. 3.5 to 4 times the suicide risk of the general population. It comes right back. So then essentially what you've achieved is a suicidal person whose genitals you've mutilated, and you've done little else for them. Okay. This is the newest document that you should have in your armamentarium, and ask for a copy of the talk, if only to get the reference to this paper, which is going to be sort of the foundational document for discussions about gender identity and human sexuality, probably for the next 50 years. Why do I say that? Because it's unlike other studies. This is a paper published by Lawrence Meyer is the lead author, and what he's looking at is over 500 studies from all different specialties, including the ones listed here, where he's just looking at the power of the study. He's looking at the discriminatory power of the study to say anything. Can this paper actually say that this has lowered the suicide risk based upon the population they've selected, based upon the quality of the observations? He looked at all of those things, and he makes some tremendous, insightful evaluations of the current literature. But one of the things that I've abstracted for you here is this: the notion that a 2-year-old having expressed thoughts or behaviors identified with the opposite sex can be labeled for life as transgender has absolutely no support in science. That isn't like maybe doesn't have support, it's like absolutely no support in science. Indeed, it is iniquitous, interesting word choice, it is iniquitous to believe that all children who have gender atypical thoughts or behavior at some point in their development, particularly before puberty, should be encouraged to become transgender. Pretty clear. Pretty clear. The scientific definition of biological sex is, for almost all human beings, clear, binary, and stable, reflecting an underlying biological reality that is not contradicted by exceptions to sex-typical behavior and cannot be altered by surgery or social conditioning. Now, that's pretty compelling. That's pretty compelling when you're talking about the examination of 500 published articles on these subjects. For him to say something that's that clear. He's not equivocating at all about what the scientific evidence actually does show. And this is important to have that in your back pocket when you have discussions at the parish, when you have discussions at your school, when you have discussions with people about the good of a particular person. You can say emphatically and without a shadow of a doubt, lovingly and clearly, no, this is not in your best interest, and here's why. But let's talk about particular examples as well. Anybody know who Renee Richards is? I mean, us older guys, yeah. Us fossils. Yeah. He, of course, is the celebrated, he's a physician who was also on the professional tennis circuit, who had these very, very strong compulsions to cross-dress, transgender thinking and whatnot. And he went through the whole transition process. And I quote him in Tennis Magazine, his own words: "I get a lot of letters from people who are considering having this operation, and I discourage them all." And he's one of the most celebrated cases of a successful transgender person. He has said that, "I just wish that somebody had helped me manage my compulsive thinking and my compulsion to cross-dress. If I had just gotten some help in doing that, I wouldn't have gone through all these other things." So it is obsessive thinking that underlies this condition of transgender. Because essentially what we're talking about here is a body dysmorphic disorder. Now, as a plastic surgeon, I'm met with body dysmorphic disorder all the time. It's one of those visits where I'm no longer the surgeon, it's more of a pastoral visit. When somebody comes in seeking a surgical intervention about their facial appearance, or about something, and you start to get into their motivation, and they start talking about their sorrows. They start talking about these inexplicable fears that they have in their life. You know that this is not the right thing to do, body dysmorphic disorders. And I'll show you some examples here. Here's Britain's youngest patient. One of the most celebrated cases in the British medical literature is this young boy whose parents took him through the whole transgender transitioning and into his adulthood, right? And then here he is on the right trying to recover his real identity. And there are many examples, and you're going to hear from firsthand experience from Mr. Walter Heyer here. I can't speak to this in the first person, but I can speak to it from the professional and my own contact with not only gender identity, but body dysmorphic disorder in general. The watchword to have in mind is that this is an interior wound seeking an exterior explanation. And it's a categorical error to offer medical surgical intervention. Okay, and then there are other luminaries in the field. For example, Dr. Russell Reed, who once the UK's best-known expert on transsexualism. This is a man who was offering amputation of healthy limbs at public expense in public surgical hospitals for people who had body identity, body dysmorphic disorder. Somebody comes in and says, you know, I'm a happy guy, but I'm convinced that this leg doesn't belong to me. Would you please cut it off? Well, obviously, I mean, that's fairly obvious, amen? Yeah. But if you go down the road of gender reassignment, you're talking about the same issue. This penis does not belong to me. I know I am a girl. It's exactly the same condition. It's just all mixed up with gender, biology, politics, all this whole gender identity thing. And so that's seen as an exceptional case, but it's really not. Here's another amazing case. Dr. Richard Curtis is a 45-year-old heterosexual woman who had transgender surgery because she's sexually attracted to men, but thought of herself as a gay male. Okay, did you follow that? Try to diagram that sentence, right? Let's see. The subject was, So heterosexual female, meaning she's a female, a woman, sexually attracted to men, but her interior identity is that she is a gay man. So she had sex change surgery so she could express herself as a gay man. Okay. But I just put this up here as an example of how confusing things get when you've got people whose limbs are being amputated. Oops. Okay, so now I'm going to present you with a thought experiment to sort of wrap this thing up. And a thought experiment is something we like to do in plastic surgery because it's a way to test another plastic surgeon's knowledge and understanding of currently available techniques and technologies. This is very popular with training directors to ask their young residents, well, let's say I have this problem, how are you going to solve it? This is a thought experiment. Well, the thought experiment that I'm going to propose to you is one that's very popular. Plastic surgeons have been using it on their young trainees for a long time, is you get a patient who wishes to have wings instead of arms and hands, right? I'm convinced that I'm a bird, and I'd like to have wings instead of arms. So you're asked to outline a series of procedures that would transform a human upper limb into a functioning wing. And we have all kinds of techniques for expanding soft tissue, for lengthening bones, for transferring muscles, for reinnervating tissues, all kinds of things that you can do in physical therapy and occupational therapy and all those things. And you can imagine how it might go. You know, on the left is a human upper limb, and then you've got, you know, a bat wing and a pterodactyl wing and an Archaeopteryx wing and an eagle wing. You can kind of see this kind of progression there. But imagine, if you will, a human person who has a wing instead of an arm, okay? All right. You can make some sort of a partial list of what would be necessary to make that arm into a wing, how much span it would have to have, how much lift you'd have to generate to get a 70-kilogram person off the ground, and so on. And you can see the difficulties there. But then you get into important things like cerebral mapping, like I hinted to you about, you know, the brain thinking penis and the brain thinking arm, and now it's got to think wing, and it's got to do all kinds of wing things, right? How are you going to coordinate that? How's this person going to care for themselves? How are they going to get food to their mouth? Birds don't bring things to their mouth with their wings. Now they have to learn how to eat with their face in a bowl, right? And how are they going to, toilet hygiene, how are they going to do that with a wing, right? How are you going to get the toilet paper, all kinds of problems, right? All kinds of problems that come into the picture, yeah? Okay, right. So when you look at it, when you look at that kind of a transition, I just use it as an extreme example to show you this problem with gender transition surgery, that essentially you're asking to change the very nature of the person, how they walk, how they eat, how they wash, how they embrace, how they sleep. And now what you have is neither man nor bird. What you have created is a monster. And I'm using the word monster in the historic, accurate, charitable sense, right? Not in the Frankenstein sense, but in the sense of something that is not quite one or the other, right? Essentially changing the nature of the person. And what you've done is you failed to apprehend, in the case of transgender, the nature of genital functioning. You've either failed to apprehend it or ignored it entirely. And what you've done is you've reduced it to a counterfeit that compromises or utterly destroys both functions. So remember, the goal is form and function. And what you have done is you've destroyed function for the sake of creating a mediocre counterfeit. And that can't be in the service of the human person. Okay? So it goes against the demand of justice in the case of what it means to be a physician, what it means to be a surgeon. It's contrary to justice. Remembering, of course, that grace came into the world to perfect our nature, not to change it, not to distort it. And human sexuality is the result of form and function, and the full truth of it cannot be appreciated if you only consider half of humanity. If you only consider that, well, this is a man, and I'm going to make that a woman, rather than understanding that the full nature of the human person is male and female, right? That there is a unitive and a procreative aspect to the genital, that nobody has a reproductive system. People have reproductive parts, that men and women together are the human reproductive system, right? Right. Okay. So what, in essence, transgender surgery does is it takes an intact person with normal form and function and mutilates them in order to obtain a counterfeit that is incapable of functioning, that's a violation of the nature of the human person and also a violation of the nature of plastic surgery. All right, I'm going to close with twins, right? Remember the twin study is the whole thing, right? But these twins are different from these other twins. Cosmas and Damien, of course, are the silverless ones, these physicians from Syria region, that poor tormented church of today. And then, of course, we have the Reimer twins. The Reimer twins suffered a traumatic loss, but they also met with an unjust denial of their nature when they deserved reconstruction. What that lad deserved was reconstruction. If you can't reconstruct it now, temporize him until you can come up with a way to reconstruct his poor injured part, right? But human pride got in the way, and what it led to, of course, was despair and death. Whereas Cosmas and Damien, the first recorded case in human history of a limb transplant, right? Now, I'm a plastic surgeon. I know what it takes to transplant parts. I know all about that, right? And even when you know everything you can possibly know today about genetics, about blood supply, about reunion of bones, about soft tissue coverage, about muscle transfers, all that stuff, it still takes a tremendous amount of divine intervention to make a success of it. Imagine how much it took back then in 3rd century Syria, right? But why would they record a case of a limb transplant? I mean, if this was just fabricated, why didn't they just say, oh, the holy men placed their hands on him and his leg came back to life? No, they took away the injured leg and they took a leg off another man who had died and they brought it in there and somehow united it and the man was restored, right? But it required a right recognition of the nature of the human person, that a human person deserves to be up on 2 feet if possible, a humble submission to God, couldn't have done it otherwise, as I've said, and a saving hope and abundant life that it led to. Okay, so this is the twin study we really ought to be, all right? Okay, all right. So, and I'll include this prayer, but when dealing with these issues, I just strongly recommend that you ask for the intercession of the good saints Cosmas and Damien in these issues, and then you'll have this prayer in your file to use when you offer those up. So, and I'm at your disposal for questions. So, yes, ma'am.
I want to know, does the sex reassignment surgery rule out normal experiences of sexual pleasure? Does it affect arousal or orgasm for people? And could this be the reason Bruce Jenner kept his male genital?
That's a very good question, and I sort of partially addressed that with the whole issue of what the actual surgery does. So if you're talking about female to male, essentially all that you can expect of that is a phallus that has ordinary cutaneous sensation. It doesn't have the neurological mapping to the brain that the genital has to very fundamental functions in the brain. It doesn't have that. It just has sort of ordinary what we call two-point tactile discrimination at best. And it's not capable of arousal like the native part would. And so for a female to male, all you're creating there is a mechanical device, if you will, for the passage of urine and for copulation that's not mapped to the brain the way the normal genital is. In the case of males to females, there is a rudimentary neural a connection that's retained in the creation of the neovagina, but it is very much degraded because of the mechanics of inverting the tissue damages some of the nerves that were present on the phallus when you inverted the thing. And so as a result, at best, you have a degraded arousability, but still the brain is mapped to thinking not receptive, but penetrative, because it's the brain still thinking phallus, okay? So that has to affect arousability. So.
Is there good psychiatric treatment for people who have transgender problems? I mean, obviously the surgery buys them 10 years of life that they maybe wouldn't have had
Right.
anyway. Is there any evidence that there's good psychiatric treatment that could buy them that 10 years or longer?
Yes, there is. And I would recommend to you, Paul McHugh is a tremendous resource and a great friend of Courage. He was the past chairman of the Department of Psychiatry at Johns Hopkins University. He's the one who discontinued the transgender surgical program at Johns Hopkins because he saw it wasn't doing the patients any good. He didn't take a political stance or any of the rest of that stuff. He just thought, hey, this is doing no good. We're wasting time and resources. We're not doing the patients any good. He recommends that we understand this as a body dysmorphic disorder that has its root in an obsessive compulsive type of process. And the management of obsessive compulsive disorders is very well characterized in psychiatry. And it involves the use of what are called serotonin reuptake inhibitors, sometimes tricyclics, but basically what you're trying to do is reduce the pressure on the mind of this obsessive thinking, and then there are behavioral approaches that can make it a much more manageable condition, right? So yes, the short answer is yes, and these are very established psychiatric principles for the management of obsessive compulsive disorders.
Thank you. They want you to repeat the question.
I'm sorry.
On
I will.
okay, the sex reassignment surgery rule out normal experiences of sexual pleasure. Does it affect arousal, orgasm, potential?
Okay, that. Right, and so this is the question we just answered, and yes, and my suspicion is, and as I hinted earlier, most people don't go all the way down the road of sex reassignment. In the case of Mr. Jenner, it's been explained, I think Dr. McHugh in one of his lectures suggested that what he has is he's sexually attracted to himself as a woman.
Okay, another one. Again, repeat this. You've spoken helpfully about surgery. What are your thoughts about the use of other cross-gender interventions short of surgery? Cross-dressing, cross-grooming, etc., in the management of gender disorders?
Well, I would discourage it. I would. So the question is, what do I think of as a plastic surgeon about the use of things short of surgical reassignment to manage the dysphoria? That is to say, would I go along with the idea of presenting as the opposite sex, or perhaps having breast augmentation, or hair transplants, or laser hair removal, or any of the rest of the things? No, I don't. And I often discourage patients who come in. Again, the idea is when the patient presents with these requests, you have to get at what's going on in their life, and you have to get at the actual sorrow that they're suffering, and you don't manage an interior wound with exterior presentation. Again, just as Renee Richards wished that somebody had helped him manage his compulsion to cross-dress, it would have been a disservice to Dr. Richards to say, oh yeah, go ahead and cross-dress, and we'll talk about this later. That was his actual problem that was not addressed.